those of you who are new to the program, I'm Pui Lee, an infectious disease physician from University Malaya in Malaysia, and I'll be facilitating today's session. Today we have our hub members, Dr. Wirasak from Thailand, Dr. Grace will be joining us from Hong Kong, Dr. Ken Kaur from Australia, Dr. Julia from Malaysia, Dr. Barry Tam from Hong Kong, and Mr. Chung Han Yang from Malaysia, Sister Ching Hong from Singapore, and Miss Priti Navin from Malaysia. So for those of you who are new or who have missed our previous sessions, you can access the recording and the slides and other resources from the iEcho platform. So before we go on to the didactic session for today, I'm going to hand the session over to Norman for any housekeeping and announcements.
All right, thank you so much. For those of you who are new, if you've not joined us, so these housekeeping rules should be for you, but those who have been with us since the first session, we welcome you back. So if you haven't already, we encourage you to change the name on your Zoom profile to your name, area of expertise, and country. And as we encourage people to ask questions, please do feel free to drop any questions or reflections in the chat box as we go through the didactic today and also the case. We also encourage you to turn on your video. We'd really love to get this session to be as engaging as possible. But we also encourage you to use the mute button if you're not speaking. We will record this session and also upload all the learning materials on the iEcho platform. There are some materials that are already on the platform, but any additional materials from this session specifically will just add on to what we've already added on the platform. Just also for your information, we also have translated caption services included in this call. So if English isn't your primary language, you can hit the translation button and captions in the language that you most prefer would appear on your screen. For Malaysian clinicians, please use the CBD form, the Google form link that will drop in the chat box. Clinicians from Japan, you can submit your certificates to JSAR as they have accredited our session. Also for clinicians, specifically at 100 prescribers from Australia, will submit your name in place of practice to ASHM for the CBD points to be awarded to you. I think that would be all. I'll hand this back over to Pui.
Thanks, Norman. So while I introduce our speaker for today, Dr. Carl Goodkin, we're also going to put a poll up on your screens for you to vote on a question before we start today's talk. So Norman, if you're so kind as to put up the poll, and then I'll introduce Dr. Goodkin. So Dr. Goodkin is an internationally recognized expert in HIV-associated neurocognitive disorders with decades of contributions to research, clinical trials, and practice guidelines. He has served on numerous panels such as the American Psychiatric Association's HIV and AIDS practice guidelines and NIH committees. Dr. Goodkin served on the consensus panel on the management of older patients with HIV infections published by the American Academy of HIV Medicine in 2012 and has revised its chapter on guidelines for the treatment of substance use disorders in older people with HIV in 2024. So his work spans research in older adults, diverse global populations, and clinical trials on neurocognitive impairment. And notably, he's also the protocol director of the global ACTG clinical trial on comparing pramipexole versus escitalopram in the treatment of major depressive disorder and comorbid major depressive disorder with mild neurocognitive disorder in persons with HIV, and that's set to begin in 2025. So today he will be speaking to us on addressing mental health and substance use in older people living with HIV. And so I'd like to hand the session over to Dr. Carl Goodkin and also say a big thank you for joining us at 5 a.m. in the US. Thank you very much.
My pleasure. And I'm excited to be here and have this invitation to speak today. Let me share my screen.
Would you like to look at the results from the poll?
Yes, please.
Okay, so we have 35 responses so far. Uh, I'm going to end the poll and we'll see what we have. It would seem that a majority of our participants have no working experience with older persons with HIV. And the second one would be depression, followed by anxiety, substance use disorders, psychosocial issues without psychiatric disorder, and we have one who has experienced working with serious mental illness.
Very helpful information to have, I think. And um, the reason that the question is structured that way is because each of those options represents a section of the lecture. Uh, so let me see then. Can you see the slides right now?
We're still seeing it we're not seeing the presentation mode yet.
Okay. I'm in the presentation mode here, so
Is your slideshow on?
it's on. Do you not see the slides at all, or
We see the slides with the tab on the left of all your slides. So it's not
okay?
in the slideshow mode yet.
I will go out and back in here of
Sure.
the file. I'll stop the share, I guess.
Perhaps when you hit share, you can choose the whole screen option.
So let's try this again. Um, I'm going to, that's what I did last time, so I'm going to try it entering into uh, the slideshow after sharing. So let's see if this works here. Okay, it's not.
You can let us know if you would like us to share your slides for you.
No, I think actually it would be better if I do it from uh, mine. So let me re-enter here. Okay, are you seeing it now?
You're not sharing your screen at the moment. Mm.
And now?
No, you have to click the share button at the bottom, Dr. Cooking.
Yeah, it was clicked. Sorry. Okay,
There
let's.
you go.
How about
Yep,
now?
all
Good.
good.
Okay. Uh, Sorry for that little delay, folks. So I'll be speaking to you today on these issues of uh, mental health and substance use in older persons with HIV. Um, and you should hopefully still be seeing this in the show mode.
No, I think you have to
Oh,
click on resume slideshow on your
okay.
screen. If you go towards the left, there's a resume slideshow option on just there, just above the search.
Okay.
Yep.
I'm not sure it's resuming it though. I did click there.
It's okay. I think if it's okay with you, we can continue in this format and we'll
Oh,
just scroll.
very good.
Yep.
So addressing mental health and substance use issues in older persons with HIV, and we'll be covering the issues of psychosocial. And with this section, I'm going to start talking about a model that I developed called the Stressor Support Coping Model, or SSC model. And the first section of that model is stressful life event burden, which relates to both major and minor stressful life events and the parameters of stressors, which include predictability, controllability, and duration of the stressor. In older people with HIV, particular stressors involve late diagnosis, stigma, minority status, financial burden, pain, and multimorbidity. The section part of uh, the second part of psychosocial context is social support, or the converse, social isolation. So it involves looking at seeking both instrumental social support ways to help you do things that need to get done, and emotional social support from others. The parameters are the availability, satisfaction, and sufficiency of support. There are many causes of reduced support amongst older people with organizational networks related to decreased mobility and not being able to make ad hoc social visits as much as one might if younger. And of course, in the future, there are plans. The third section of psychosocial context is coping strategies, active versus passive strategies in terms of the environment, adaptive versus maladaptive. So generally, active coping strategies are adaptive and help you manage stress, while passive coping strategies are generally maladaptive in coping with stress. Coping self-efficacy is a sense of being an optimism, being effective in coping. Um, it's very important to try to increase active behavioral coping and decrease denial of stress and disengage. Increasing access of social support, very important as well, and increase finding meaning. All of that under coping. This is actually a slide of the SSC model. And here you can see the external world, if you will. And on the right, there are stressful life events which can worsen uh, distress. Uh, However, if they're predictable and sufficient, it down modulates the relates to decreasing psychological distress and all of the ramifications that decreasing distress has in terms of helping people manage a disease like HIV infection. Of course, if you have the opposite scenario, it goes the other direction and you have increased distress and progression of disease predicted by the model. Here you can see a factor structure rendition of the same model. On the left, you have different stressors down here. At the bottom, uh, up top, you have social support and coping strategies, and those are associated with resilience or regression. That's measured in terms of outcome variables related to functional status, physical well-being, mental support specifically. Social support has been linked to CSF inflammation in aging people with and without HIV. Um, and in one study, it was related to uh, a composite measure of two inflammatory biomarkers, MCP1 and IL-6. And you can see a graph over here on the right, where if you have increased support, you have a decrease of this inflammatory index that is significant. And I should say that this index was uh, more strongly related in CSF than in the plasma. Okay, next we're moving on to our second section of depression. Types of depression is important to be aware of. Major depression or major depressive disorder being uh, the most commonly referred to form of depression. So let's talk about depression amongst older persons with HIV. Um, Despite substantially higher prevalence of depression among persons with HIV, there's still little data on incidence and correlates of depression in older persons with HIV. Um, in a sample of persons without HIV, newly diagnosed with HIV and previously diagnosed with HIV, which you can see here in this slide on the right, the risk of depression increased with age and over the time period observed in recent years. So depression has been increasing despite the effect of antiretroviral therapy, uh, which is counterintuitive to many, but is the case as has been shown by numerous studies in the literature. In this slide, you'll also see that men are represented on the left, women on the right, and women are particularly more likely to be depressed in the setting of newly being diagnosed with HIV, whereas men are more likely to be depressed if they have been previously diagnosed with HIV. So this highlights the need for the integration of mental health with primary care in HIV, which is an overarching concern and relates also to this sexual dimorphism, if you will, regarding depression. What about the Asian Pacific cultural context in depression in older persons with HIV? So, in a multivariate analysis, moderate to severe depression uh, symptoms were less likely in patients with older age and HIV at the time of study assessment. This study by Ross et al., 2022, versus uh, those who were aged less than 30. So both a middle age group, 41 to 50, and uh, one greater than 50 showed this difference compared to younger persons. And this sample was from Malaysia, Hong Kong, the Philippines, South Korea, and Thailand. So cultural variation in depression prevalence is very important to be aware of, with an actually lower rate by age in the Asia Pacific region. Lifetime depression in older persons with HIV and suppressive art and inflammation is uh, examined in this study, in which a sample of older people with HIV on suppressive art uh, were looked at in terms of uh, elevated plasma neopterin level. And neopterin was related to a clinically significant depression history, but only among people with HIV who are on the right here. You can see the difference. It's not significant in people without HIV on the left. So it's important to be aware of from this that there's a specific interaction between HIV and depression that increases inflammation. I want to briefly talk about the comorbidity of depression and HIV-associated neurocognitive disorder, or HAND, also referred now to as HIV-associated brain injury, or HABI, as the nomenclature of HAND is being re-examined. And we know that depression and HAND are the most common neuropsychiatric conditions affecting people with HIV generally, depression being 2 to 4 times more common amongst people with HIV than the general population, and HAND ranging from 25 to 47% of people with HIV in prevalence, depending on a variety of different factors in the studies done. HAND is also more common with older age. Both MDD and HAND, the major depression in HAND, result in substantial morbidity and premature mortality. Yet the comorbidity of these two disorders has not been formally studied. Symptoms overlap has been, but not the syndromal level. So we need research in this area. And I already mentioned the overlap in pathophysiology related to neuroinflammation, which affects neurotransmitters that relates to antidepressant treatment choice. So this is directly relevant for treatment. Let's move on to the next section, which is on anxiety. Important to be aware, anxiety is not equivalent to stress or distress. Um, and distress is a general term for mood dysregulation, not specific to anxiety. And stress uh, is a generic term, and stressful life events need to be thought of as separate. There are numerous types of anxiety, one of which that's particularly important is anxiety associated with trauma, particularly for women with HIV. What about anxiety in older age and persons with HIV then? Anxiety is much less well studied than depression in older people with HIV. Uh, in this study, participants included 163 uh, older persons with HIV, 113 younger persons with HIV, 95 older people without HIV, and 75 younger people without HIV who completed a profile of mood states um, and an interview, uh, diagnostic interview. Persons with HIV had significantly higher rates of anxiety symptoms, as well as 12-month and lifetime diagnoses of generalized anxiety disorder and panic disorder, two common anxiety disorder diagnoses. There was no significant effect of age and no significant interaction between HIV serostatus and age. Yet the subsample of older persons with HIV were significantly older at the onset of their anxiety diagnoses. Here's another study related to anxiety, uh, an observational cross-sectional study of 152 persons with HIV uh, related to age effects and also estimated duration of HIV. All were cisgender men and completed the profile of mood states. And results showed higher levels of anxiety in persons with HIV compared to those without HIV. Age group moderated the effect of duration of HIV, with younger persons with HIV with early diagnosed infection showing highest anxiety levels. Anxiety was attenuated in older persons with HIV with early infection, as their scores did not significantly differ from those without HIV and with chronic HIV. Um, Older people may have a greater adaptive ability to manage acute life stressors uh, that occur with recent HIV. However, older people with chronic HIV were more likely to experience higher levels of anxiety. In this study of anxiety among persons with HIV in Guinea to look at cross-cultural differences. Uh, the study looked at 160 persons with HIV at a university teaching hospital, and the prevalence of anxiety symptoms amongst persons with HIV was high at 14% by the hospital anxiety and depression scale. Um, Age less than 40 was significantly associated with higher anxiety here. And similar anxiety findings uh, epidemiologically with decreased anxiety issues in older persons than was found. So let's talk a little bit about the cultural context of anxiety and aging in the Asia Pacific region. One study of anxiety in persons with HIV related to this with an N of 121, uh, and those without HIV with an N of 61 used the SCL-90 checklist in China, uh, showed that both anxiety was higher amongst persons with depression, anxiety, I should say, with both shown higher amongst persons with HIV. Anxiety was associated with younger age and increased alcohol consumption. Anxiety was also associated with decreased sense of vitality and a decreased social functioning.
Dr. Goodkin, just to let you know, there's another 4 minutes.
Okay.
Thank you.
Uh, So we'll go on to substance use and serious mental illness, trying to move a little bit more quickly. Aging and substance use has been a neglected area of research generally. Um, Comorbid use of substances is very common. Comorbidity with primary medical disorders is also very frequent uh, related to substance use. And screening for substance use needs to be done routinely, particularly for older persons with HIV, which is little appreciated. Um, Epidemiological data from population studies in the US show a substantial decline in rates of substance use disorder with progressive age in the general population. Um, and Early on, data suggested, unlike older persons without HIV, where rates of disorder declined substantially compared with younger adults, this was not the case for older persons with HIV. So older persons with HIV relatively more likely to have substance use issues. Cultural context is very important in this regard. Um, Moderate to high risk substance use found in 62% of users was associated with younger age, being male previous stressors, and suboptimal adherence. And I would say that current data from the Asia Pacific region show that opioid use is uncommon, although this was generally assumed to be one of the most common substances focused upon in previous work. And it's now recognized really that tobacco and alcohol use, as you would expect, would be more of a common focus along with cannabis use and unusually high level of inhalant use in the region. So we know that the influence on quality of life of substance use is significant. And of course, that substance use is associated with negative effects on quality of life. in terms of the issues in this area more generally, it's understudied. Um, and I won't go into this further due to time, but I think it's important to be aware that substance use is a primary predictor of engagement in sex without condoms and non-adherence to art amongst older persons with HIV, as is true with younger persons with HIV. Uh, Close to 25% of older persons with HIV meet criteria for substance use disorder, and ageism with respect to this has no place. We really need to be having a high index of suspicion for substance use issues. I now want to turn quickly to serious mental illness, which is uh, most importantly to be recognized as an area that is overlooked in research related to people with HIV generally, and particularly older people with HIV. So when we're talking about SMI, we're talking about disorders that are typically manifesting with psychosis. Uh, and the lack of cultural context in this area of research is also notable. Very little cross-cultural work in this area. We do know that in terms of older people with serious mental illness, older age was associated with inaccurate HIV knowledge, and older age is associated with increased risk for contracting HIV amongst this population. And here you can see, just to summarize quickly, in a study of psychiatric inpatients with serious mental illness, that the usage of art uh, was low. It was only 39% by the time of discharge across these years you see here, even though it is going up in more recent years. And this points to uh, the importance of exploring in future studies interventions to increase art prescription during hospitalizations to avoid increases in viral load and potentially clinical, sequelae as well. Also, this points to, of course, the need for integrated care.
One more minute.
Okay. So future prospects of care for older persons with serious mental illness. One of the most important things is down at the bottom, investigation of combination treatment of long-acting ART and long-acting antipsychotics. And I should say that I have already proposed that this type of research should be done, but there have been no such studies to date. The combination would really increase the likelihood of adherence for both art and psychosis treatment. Solutions of all of these problems, first, are too few. Too many studies are cohort studies of older people with mental health issues with no treatment implications. Um, and we need treatment focused trials. So I won't go into each of the areas related to solutions in detail, except to say that psychosocial context is important. Without any psychiatric disorder, people with high life stress should get stress management interventions. People with low social support should get social support group interventions. People with poor coping strategies should get coping enhancement skills training. Um, Depression is very important to look at specifically the aim for full remission of depression and ensure ongoing treatment and maintenance antidepressant therapy. Anxiety needs to be further studied. And we need to screen for anxiety disorders more actively, particularly PTSD. Substance use disorder. The risk for older persons is underestimated, so active screening very important. And of course, it relates to adherence optimization and reducing transmission risk. And finally, the SMI, serious mental illness group that I have just summarized for you and the importance of addressing their needs. Uh, and part of that is making PrEP more available to this group and improving their knowledge and having tailored interventions for prevention that can be used in this group. Integration with primary care is a contextual issue that's generally important. Cultural and religious differences are very important to pay attention to as they relate to care preferences. Um, and that can make it difficult uh, in integrated care to try to attend to those issues. Health literacy needs to be improved. Older people need to be recognized as potentially passive, so you need to reach out to them more actively related to mental health care. Stigma is a major concern in terms of expressing mental health symptoms and actively prescribing strategies to improve mental health in older persons is very important beyond medical care in terms of medication treatment to look at scheduling social interactions, physical exercise, mental exercise, dietary interventions like the Mediterranean diet and sleep hygiene. And with that, I'll end.
Thank you very much, Dr. Goodkin. Um, there are one or two questions in the chat box. Maybe I'll read it out if that's okay. I think maybe we'll have 5 minutes for a Q&A, if that's okay. So I think the first question from Jepchire, sorry if I'm saying it wrong, from Kenya. What are some of the tools used to assess substance use among older adults living with HIV?
Okay, so tools used to assess substance use. Um, First, I should say that a psychiatric interview to define whether or not there's a substance use disorder is very important to do. And there are standardized interviews that can be used for this purpose, such as the SCID. Um, Also, there are specific questionnaires that can be used for substance use screening. There's general substance use screening that can be done, for example, with the drug abuse screening test or DAST. There's specific substance use screening, for example, the audit for alcohol use. There's also specific substance use screening tests for cannabis use. So you may want to be very specific depending on the concern that you have in the screening process. Uh, so interview and screening test, general screening test, and specific screening tests.
Dr. Goodkin, what do you think about the assist tool? Because I think that's something that we use back in Malaysia.
Yes, as a matter of fact, one of the studies that I was summarizing used assist. And I think Assist is a very good instrument to use as well. I mean, there's a, a significant number of instruments to choose from. We don't have the time to go into, the differential pluses and minuses of each of the instruments. But yes, Assist is a well-recognized effective tool.
Okay, that's great. Maybe that's something that we can share in the resources after the talk today.
Uh,
Sorry.
I was just going to mention that in the links that I provided for the American Academy of HIV Medicine uh, chapters related to managing HIV in older people with HIV. Uh, I have my own link for the substance use chapter there, and you'll find all of these tools discussed in detail there with, their relative pluses and minuses included.
Oh, thank you very much. And I think I'll just have one final question for now. What is the role of primary care physicians in doing screening for psychiatric disorders or substance use disorders? And when is the best time, which clients do we need to pay more attention or care to?
Okay, so the role of the primary care physician is critical. We don't have enough psychiatrists to rely on psychiatrists to do this. We don't have, in fact, enough mental health professionals generally to rely on mental health professionals to do this. That's why we really have to have integrated care where our primary care providers understand that they are key in screening for mental health and substance use disorders. My perspective as a psychiatrist, mental health and substance use are really all mental health. But it's important that the PCP embraces this and feels empowered to screen for these disorders and treat, at least at an initial level, and then turn to mental health professionals for when treatment might be complicated. And for example, in terms of major depressive disorder in people with HIV, uh, the predominant number of people with major depression are treated by primary care providers without mental health
Hmm.
professionals being involved. And
Hmm.
this is also true more generally, in the general population, not just those with HIV. The primary care providers uh, are typically the first uh, provider treating major depression. So, um, I think that we already do rely on primary care providers, but if anything, we need to bolster their sense of efficacy in
Hmm.
screening and treatment.
Um, Thank you. Actually, I was wondering whether Ken, if you're there, what do you think of, or do you want to expand a bit more in terms of, what type of mental health screening and role you play?
Thanks, Puli. So in my practice, we screen during the semi-annual care plan appointments that we do with people with HIV. We have a very simple uh, two-question screening for mental health. I can't remember the exact name of it at the moment, but we also do a substance use screen, asking whether people feel that they have a problem. Um, So it's done every 6 months, really, with people with HIV. I think it can be done at any time. And I agree with the speaker that primary health is vital, I think, in picking these things up because, well, in Australia, primary care is the first line of contact with healthcare, right? I think it's a little bit different in Asia with access to specialists being structured a little bit differently. So I think it's really important.
Yeah, and I suppose it's non-age dependent and just generally something we should screen for in everyone.
Hmm. Oh,
Okay.
the other thing that I want to quickly mention, I've mentioned this before in previous sessions, is using a quality of life questionnaire. So we use POSQUAL, and that provides an entry into the psychological domain. If people are reporting low scores, and that allows us a door into that discussion as well.
Thanks so much. So I'd just like to say a great thank you to Dr. Goodkin and for this session, and for Ken for sharing your experience as well. So I think what we'll do in the interest of time is go into the case presentation.
Very good. Although, let me just add a point related to Ken's comments.
Yep,
Uh,
sure.
One of the things to think about related to major depression screening is that you don't have to use most people being very familiar with the PHQ-9. You can actually use the PHQ-2, a two-question screener, to pick up major depression, which is under-recognized and undertreated generally in people with HIV, and particularly with older people with HIV who tend to express their depressive symptoms more somatically rather than in terms of affective or cognitive aspects of depression, like hopelessness, helplessness, and low self-worth. So important to think about that. Just two items for depression screening. And there's a one question item, a screener for alcohol use disorder. So the very, very brief screenings can be done effectively.
Thank you. That's so true. And I think oftentimes it's just asking people how they are feeling, and that often just segues into all of this as well. Uh,
Absolutely, and that's where the PCP really plays that effective role because they already have that rapport,
mhm,
built with the patient. Whereas you bring in an outside mental health professional, all of a sudden everything looks a lot different to the
mhm.
patient, and the patient can really sort of become less responsive when you want them to be more responsive.
Yeah, definitely. And actually, so if that's okay, we'll go into the case presentation because I think that kind of like illustrates what we've been discussing really well, actually. So
Very good.
thank you. So if it's okay, I'll just share my screen. Um, Dr. Goodkin, would you mind to stop share your screen? Mm. All right. Can everyone see my presentation? Okay. So I'll just be sharing a case. This is a case that was actually highlighted by our psychologist, Miss Chong Ming Lee, but she's not able to join the call at the moment, so I'll be presenting on her behalf. So just so I'll be talking about a gentleman who's 42 years old. We'll call him ABC. Just to protect his identity. I know he's not reached the threshold for older persons, but he does illustrate the point very well. So he's a 42-year-old male of Indian ethnicity and from the key population of men who have sex with men. He actually presented to the emergency department back in 2014 with aggressive behavior following his late brother's suicide and was diagnosed with bipolar mood disorder. And during that presentation, he was incidentally tested for HIV and found to be positive with a CD4 count of 50. He was then commenced on antiretroviral therapy, and the first line here in Malaysia is tenofovir disoproxil, emtricitabine, and ephedrins. And he was also started on sodium valproate for the mood disorder. And throughout this time, since 2014, he remained engaged in care, both for the infectious disease team as well as the psychiatric team. And in 2022, later on, he was diagnosed with diabetes as well, with a HbA1c of 8%. So he started seeing our psychologist in the ID clinic in May of 2022. And he was engaged with the psychologist up until October 2022. And during the conversations with the psychologist, he also mentioned that he was not very compliant with the psychiatric medications. And with the psychologist was working with him on building social skills because he actually had been socially isolating himself for the last 10 years. And the reason behind this as well was that before all of this in 2014, there was a lot of mental health stigma in the family. So I think there was some history of mental illness within the family. And so there were occurrences where they would chain him to the bed if there were visitors and things like that. And that happened very early on in his life. So because of that mental health stigma that is there, I think there was a tendency to socially isolate. And in fact, he actually engaged in our psychologist care by chance during a qualitative interview during a research that we had been conducting. So it wasn't something that was picked up by our team and referred to the psychologist for further intervention, because at this point we were not routinely screening for mental health or substance use. And during that time, we found that he was moderately severe depressive with anxiety symptoms and a high suicide risk. And later on in December of 2022, during his routine ID visit, we noticed his viral load was not suppressed, and it had gone up to about 2,200. And this was actually due to a trigger where he came into contact with his family members, and that kind of set off a lot of his symptoms again. So he was non-compliant to antiretroviral therapy. He only took his antiretroviral therapy once or twice a week, and also non-compliant to his diabetes medications, as his HbA1c turned out to be 12%. Unfortunately, during that consultation where we identified that his viral load was not suppressed, and we also advised him about his diabetes, that communication made him feel very judged. So that consultation made him feel very judged, and he actually subsequently defaulted all of his medications. And he also disengaged from psychiatry care during that time. He re-engaged back with the HIV physicians back in March of 2023, and then agreed to restart his antiretroviral therapy. And 2 months following that, his viral load had come down to about 739 copies. He also re-engaged with our psychologist, but only for about 5 months. And then he was referred to a non-governmental organization for ongoing therapy because our therapist was unavailable, but he did not attend the non-governmental organization. He then re-engaged with psychiatry in February of 2024 because he had very low mood triggered by work. And so he was seeing a new psychiatrist, one that he's not used to, and he was started on sertraline. But due to inadequate communication, he did not take the sertraline. So this was actually because the psychiatrist that he used to see told him that he should never go on an antidepressant, as it would make things worse for him. And so when he was told to go on an antidepressant, I think there was lack of trust or a lack of a relationship there, in order for him to start himself on sertraline. Later on in that year, he re-engaged with the psychologist, and he was referred to a dedicated psychiatrist. So the psychologist had a conversation with one psychiatrist, and then he remained with that psychiatrist throughout. And in August of 2024, he was started on cariprazine, and things improved significantly, and he remains engaged in care. So once his mood improved, then there were discussions with the psychologist about issues with his diabetes control. And we explored reasons for the defaulting, and it was due to diarrhea from the metformin. And he also did not see it as a priority because obviously his mood disorders predominated things. So the psychologist had a chat with the ID doctor, and the patient also engaged with the ID doctor, and his metformin was changed to extended release, and his previous glycoside was also stopped due to hypoglycemia. And obviously lifestyle interventions and other things were discussed. In September of 2024, which is this year, the ID physician picked up on the interaction between Kaletra and cariprazine, and he was then changed to dolutegravir and lamivudine as a 2-drug regimen. And just to note that in March, his viral load was 30 copies. However, at the moment, his viral load remains at 122 copies. So in terms of his antiretroviral therapy regimens, this is just a list of what I had mentioned. He was initially on tenofovir, emtricitabine, and efavirenz, and then was changed to Kaletra and Kyvexa in May of 2015, and achieved viral suppression from 2015 to 2022, and then was on dolutegravir, lamivudine from September of this year. This is actually just a list of his psychiatric medications. I'm not going to go through this list, but I think this is really just to emphasize the number of changes and challenges that people with co-occurring mental health illness go through, apart from just the HIV treatment. So on the left, we have all the different changes of his psychiatric medications, and on the right are just some medications for his diabetes as well as a statin. So his viral load trend was, as I've mentioned before, and it's at 122 at the moment. His HbA1c in November of this year has improved, thankfully. And just some social factors about him. He's single, he's not sexually active, he has no current use of substances, although he did say that he tried amphetamines once in 2014. He lives alone. He works as a lecturer. He's estranged from his family, even though he reconnected with his sister earlier this year. And in terms of social support, he gets some support from a colleague who also has a mental illness. And in terms of supportive social factors, he enjoys cooking. So I guess what I want to discuss for today, and I'll open it up to everyone, would be, how as us as ID physicians improve our communication and relationship with people with mental health illness, especially when there are constantly different and conflicting priorities, for patients. Sometimes it's their mental health, their HIV, their diabetes. And also discuss about the choice of antiretroviral therapy, whether you would use a two-drug regimen in this case, and also about some of the drug-drug interactions. So I'm just going to stop sharing my slides here, if that's okay. And maybe I'll open the floor to Barry, unless there's anyone with like immediate questions. Yeah. So Barry, do you mind if I ask you, in terms of, what do you think about this case, and how can we approach it or do better?
I just want to know a little bit more about the history
Mhm.
of the patient, because I know that there is quite a good detail of how the patient is coping with HIV. But I mean, as a psychologist myself, and I would probably want to see a bit more about his personality, because it would also be another factor that we might have to consider when we build up a relationship with a client. So I don't know if you might be able to tell me a little bit more about how you feel about him as a person.
Um, I haven't personally met him, so I don't think I can talk too much to his personality, but could you maybe elaborate a little bit more about how that plays into
Yeah, I mean,
informing me?
I don't want to frame a patient like having personality disorder, but everybody will have a little bit of a personality trait in I mean in their personality. So it might come to it comes to it's sort of come to my mind that an experience in our clinic. It was like a patient who had difficulty in building a relationship with others, and he was quite avoidant of close relationships. So this patient actually had a conflict with one of our staff quite a couple of years ago. But I mean, at the end, when I spoke to him, and I noticed that it was something also related to his childhood background. He has a long history of childhood trauma that which makes him feel like very difficult to trust others. So sometimes I think knowing a little bit of the history of the patient will be able to help us to see how he sees the world and how he sees himself. So I know that in the clinical psychology, I mean the clinical health psychology perspective, that we only see like sort of the CBT kind of way, that seeing things at the here and now, but we also need to consider like a wider spectrum, how the person comes to be and becomes a person today. There might be some history that we might have to consider as well, that might help us to see how we build a relationship with others. I think this is also something that might explain why patients are not engaging in the mental health system as well, or the healthcare system in general, that they might find it difficult to trust someone, or they might find it not very. I mean, it's sort of like an attachment style, especially if those person who have like a fearful attachment style, that they would consider themselves as a person not being welcomed, and they will also think that other people might be more likely to reject them. And in this sense, then these type of persons or these types of patients might be more difficult to engage in the healthcare system, or to build a relationship or therapeutic relationship in general, if that makes some sense.
Yeah, it does. I mean, I'm just trying to think, so I guess this is where integrated care becomes really important, right? Because I'm just thinking as a HIV clinician, or maybe even as a HIV clinician, sometimes we don't dwell too much into the past relationships, because I think when patients see us, they're thinking really, they're really focused on their HIV and other comorbids. And I'm just trying to think like, how can we understand that? Do you know what I mean? Like how can us as HIV physicians or primary care physicians without that psychology background actually get to understand that in order to know how to communicate better?
I guess it's sort of like like a general thing, like being chatty. I think this is something that my team has been doing really well. That they've been really chatty when they first met the patient. So I mean, I sometimes I mean I would normally not be the first person to see patients in our clinics, because I'm a clinical psychologist. So they went through seeing a nurse, and then went through seeing an ID physician, and then coming to me. And then so I would probably be the third person, or the fourth person that they've seen in my clinic. But they usually would speak to me, would tell me about their experience of seeing nurses or ID physicians in our clinic, that they find our colleagues really chatty, so that they feel safe to talk about the past, and they feel being interested in being known. So they feel like okay to talk about things that they want to talk about. So it is also something like um, I mean, we can just start from the general, but then later on, when they build the trust, they will be more willing to tell you more about what happened to them.
Mhm.
Um,
So it's very important to kind of build that relationship up front.
Yeah, and I really want to highlight there was a research about the attachment style of people living with HIV, and then the findings was people living with HIV usually have more fearful attachment style. This is what I just explained.
Sorry, fearful. Okay.
Fearful attachment style, that they would usually perceive people as more rejectful, and then they being a person as an unwelcome person. So that add up to the negative prediction or anxious prediction that the next relationship, whether in a clinic or whether outside of a clinic, it would be a painful one.
Mm.
Yeah, so sometimes we have to be even more warm, even warmer, to help them to engage in the system. So some of my patients, they tell me very the comment is really strange, because they sometimes, some of my patients might have to attend a general geriatric clinic, but also to
Hmm.
attend to our HIV clinic. And then they found staffs on the HIV clinic very different from the general geriatric clinic,
Hmm.
because we have to be more nice, I mean, to nicer in order
Yeah.
to help them to engage in the system, to help them feel safe. So this is, I think it's no
Hmm.
formula to do that, but just being nice and chatty.
Just, yeah, person-centered care.
Yeah.
I think, Andrew, I'll come to you in a bit. I just want to maybe ask Grace about what she thinks about the antiretroviral therapy choices.
Yeah. Well, actually, Jenny and Puri and I had some discussion before this presentation, as Jenny is not available today. So I guess there are some limitations. We don't have resistance mutations results. So it's really from the history of ART and also the current viral load trend. So I guess the INSTI-based regimen, I think it should work in this patient. He's not previously exposed, and previously, if I got it correctly, there should be some adherence issues at some point in time with interruption in treatment. And after re-engagement, there seems to be quite good control in terms of viral suppression. So I guess if there are some blips, adherence might be the reason rather than true resistance issues. I think I probably would just press on with the INSTI and avoiding protease inhibitors because of the multiple medications, and I guess there would be some drug interactions. So, and another issue I would actually like to raise is I think from this patient's experience in the clinic, it's actually a very good reminder for us as ID physicians that even if we don't know all these counseling or therapy techniques that Barry and other psychologists are very experienced in, I think at least we do know how. You mentioned about the person being judged after we sort of question them on adherence and poor glycemic control. And I think these are really things as clinicians we are very eager to work well with these problems. And many a times when the persons in front of us, if these are not really their life goals, at least at that stage in their lives, then there's really no point going into adherence and glycemic control and heme stakes and diets, etc. So I think we should really be sensitive. People will change over time. So at that point of time, we should be sensitive as to what's the major goal, the priorities at that time. And if things go well, I mean, at a later stage, we can always go back to lifestyle, diet, medication adherence. So I think that's something we should learn from our patients, really.
So, I mean, just two things. One's a question, one's a comment. So I guess in this case, do you think he should be on Kyvexa and dolutegravir, or do you think dolutegravir and lamivudine is sufficient?
Well, I would say two NRTIs probably would be safer, given that we don't have a resistance test. So, well, having said that, if it's a 184B mutation, then there are evidence that things like Biktarvy or even D3 regimen could work, but mostly those are in patients with a rather long period of viral suppression. So for this patient, probably two NRTIs would be safer.
I guess just one comment to reiterate what you've said is I think that's why it's so helpful that in some clinics they use PROMs, patient-reported outcomes, because from the outset it asks, what are your priorities? And so actually just by asking that, it really helps to shape the direction of the consultation. So yeah, I thought that's just something to kind of like reiterate, because I know we've been discussing it over the previous sessions as well. Thank you. Priti, do you have any comments in terms of, the drug interactions and how like systematically we could have maybe prevented that?
Hi. So I think one of the important strategy which we all often overlook is the practice of medication review or medication reconciliation. And I think, and I guess it's most often overlooked because of time constraints and high patient volume. So what I would suggest and what we do in our clinics is that we actually have visual cues at like sticky notes, alerts at each consultation room and even at each computers of our doctors. And I think establishing a communication with the pharmacists, that is including pharmacists in the outpatient team, that will proactively identify potential medication issues will be also helpful. I think another strategy would be to incorporate medication review into the standard checklist during medication prescribing. Especially in computerized hospitals, this I think would be easily, add-ons such as review current medications as a mandatory checkbox in each patient encounter will be also helpful to circumvent any drug-drug interaction issues. The other thing would be also hospitals to utilize utilizes computerized systems to have like provide an easy access to drug-drug interaction databases that can potentially summarize all the potential drug-drug interactions. Yeah, so these are some of the uh, uh, ways that we can circumvent drug-drug interactions.
Thanks, Pretty. Grace, I think there's a question in the chat box. So I was just wondering if you could respond to that while I ask Sister Cheng Hong to maybe, and also Ken, maybe just to share whether they have any experiences managing these type of situations or patients.
So you mean the question on the long-acting?
Yeah.
I think we had the discussion as well. And I think unfortunately the regimen is currently not available in Malaysia. But for rilpivirine, I'm not quite sure because this patient did have an NRTI exposure. So without the resistance testing, this might be an issue for this patient. But having said that, in general, for people with adherence issue, actually, I do think that selected patients, long-acting injectables could be a way out, but it's really for selected patients. So some people, if their adherence is mainly due to difficulty in taking in drugs every day for whatever issues, it could be social issues, not convenient to take drugs in a private setting, etc. And they are willing to come back really like every 2 months. For these patients, it's actually easier to engage them because they do have to come back to the clinic. I think for selected patients with adherence issues, injectables is certainly a solution. But really, we need to discuss that. Yeah, and then for this patient, of course, the resistance could be a problem.
Yeah, I think especially with the treatment experience. Cheng Hong and Ken, do you want to share whether you have any experiences with similar patients and how you addressed it?
Actually, I think I will just go first. So in my Jelly syndrome screening clinic, I do see quite a number of patients. They may not be very elderly, maybe 50-ish, suffering from mood issue, anxiety, and the very significant phenomenon we observe is that they often report subjective cognitive impairment. And when you do a formal cognitive assessment, actually the score okay. So we know that mood issue and then sleep, substance use has great impact on cognition. And due to the mood issue, sometimes carry on intervention, recommend like sleep hygiene, behavioral change, exercise regime, social prescribing can be very, very challenging. So these are the things that I often face. So far, I feel I don't have a solution to it, but I feel spending a little more time and talking to the patient will help because at least there's a rapport and the trust built between the provider and the patient. So after a while, they'll be more open to the suggestion we have made. Yeah.
Dr. Goodkin, I was wondering whether you have any comments in response to that.
In general about the case or?
To Sister Cheng Hong's comment on the subjective cognitive impairment.
Yes, so subjective cognitive impairment is something that you have to be very careful about acting upon in terms of investigating a hand diagnosis on the basis of, because it's not necessarily associated with changes in objective neuropsychological testing. For example, it's been well demonstrated that patients with major depression and also relevance for bipolar disorder in the depressed phase, that depression complaints actually don't correlate with changes in NP performance. So the patient will say their memory is worse, but when you test it, you won't find that to be the case. So this is something that's generally a concern in working up hand in the setting of a comorbid psychiatric disorder of other uh, type. And you might want to prioritize trying to get more objective neuropsychological assessment done, although I recognize that very frequently that's a commodity that's not always very accessible in primary care HIV clinics. So it's a tall order many times to get that done. And there are some ways to look at that without getting a neuropsychologist. For example, you can use the cognitive functioning subscale of the medical outcome study, HIV functional status scale, also called the MOSE HIV. It's 4 items, and you can get a better sense objectively of whether or not there is a change in neurocognitive performance rather than just what the patient tells you from that.
Sorry, I was on mute.
Yeah.
I was wondering, before I come to Ken, maybe I'll just take Andrew's question. Andrew,
Hi, thank you
thank
very
you.
much. Dr. Goodkin, I'd just like to find out for patients who are aged or getting elderly, there tends to be a trend for a lot of these patients who are reaching retirement age to move out of the big cities away from their regular treatment centers. So what they would do is probably because of the cost of living and everything, they may move towards a more rural area where life is simpler, less expensive, and things like that. So I'm just thinking that increasing the frequency of their clinical visits, whether it's to a psychologist or a psychiatrist, may not be that easily accepted or managed by them because of the distance. How would we be able to implement remote screening of some sort where they could do it on their handphones, on the laptops, wherever they are, to create a continuous linkage to a system of feedback to their primary care physician so that this could be sort of identified a little bit earlier and maybe to link them to a uh, uh, NGO, whether it's to mental health or HIV specific NGO, where they could get peer navigation, peer support, and just something to help them manage their issues of emotion and frustration or whatever they're facing. Thank you very much.
Very good. So let me just begin by saying that it is an issue for people with HIV to move into rural areas upon retirement. Um, in terms not just of care accessibility, which you highlight, but also related to an increased likelihood that they will be less active physically and mentally in a rural setting where they're more socially isolated. So all of those things complicate uh, being able to age positively with HIV. Uh, that said, what to do about it? Well, the most important part, of course, is to maintain care uh, engagement uh, after such a move. And I have significant amount of experience in using telepsychiatry. I think that in terms of primary care as well, This can be done by telemedicine too. Um, and I should say that telepsychiatry has been studied and been found to demonstrate non-inferiority to in-person mental health care. So it's significantly beneficial to set up telepsychiatry visits for follow-up if you need to do that to manage the patient as they move into such an environment, which, I would again not be surprised by, even if you make very good plans about how to try to keep the care plan intact after such a move.
Thanks, Dr. Goodkin.
Also, I would add that phone apps can be used. You alluded to this. There are phone apps for psychotherapy available. There are phone apps available for neurocognitive testing currently. So phone apps are extremely helpful and broaden the impact of what can be done with telepsychiatry using Zoom visits, for example.
Thank you. I'm so sorry to have to cut in. I think just because I think we're running a bit late with the session, but I think I totally agree with leveraging technology to help reach people in need of help, especially when it has to do with mental health and if they're moving away. So I'd like to say thank you to everyone for such an engaging conversation and discussion, and for staying on for so long, for so early and so late as well for some of you. And I'm just going to hand it over to Norman for some quick announcements before we end the session. So thank you very much.
Thank you so much, Prilly. This would just take a minute. For Malaysian clinicians, the Google form had some issues earlier on, but we believe that it's been rectified. So if you access the same link, it should work now. But if you still encounter issues, don't hesitate to reach out to us, and we'll get it sorted for you. As usual, we are looking for a case for the next session. Our next session will be in January, January
the
8th. Yes, January 8th, at 6 p.m. So we're going back to 6 p.m. Malaysian time. And it will be on healthy longevity. And so the case ideally could fall under the same topic, but it doesn't have to follow the topic. If there's any case based on these older persons with HIV, we welcome that. Apart from that, feedback is important. Your certificate for the attendance here in our session today is contingent upon the completion of the feedback form. You would have to be logged on the iEcho platform for you to complete the form. So be sure to do that for us to send over the certificates to you. Yep, that would be all.
Thank you so much, everyone. And so we'll just draw a session to the close. Thank you.
See you next month.